Hi all, welcome to EduWizz Academy. EduWizz Academy is providing online program for nurses who are preparing for licensed exams to the Gulf countries like DHA, DOH, MOH and Prometric. It's an online application program which includes 35 hours of exam-oriented theory classes, study materials, mock test, exam test and many other features, including faculty assistance. We also provide classes for lab technologists, technicians, pharmacists, and many other professions. To know more about our app, please contact us directly. So let's go to our discussion straight away. So first question, which of the following drugs is the antidote for magnesium toxicity? It's a simple question. We have discussed this earlier also. Which of the following drugs is the antidote for magnesium toxicity? So options are A. Calcium gluconate, B. Hydralazine, C. Naloxone, D. RHD or RHO immunoglobulin or RHO gamma globulin. So magnesium is a drug which commonly used during pregnancy to prevent complication called as eclampsia. So in pregnancy-induced hypertension, there are three conditions basically: gestational hypertension, preeclampsia, and eclampsia. So in preeclampsia, to prevent eclampsia or seizure, we give magnesium sulfate. So we have to check the therapeutic range of magnesium, and we have to give antidote if there is magnesium toxicity. Therapeutic range of magnesium is 3.5 to 7 or 4 to 7.5. That it stands between that range. So if it is more than 7.5, it's magnesium toxicity, and we have to give the antidote of magnesium sulfate, which is calcium gluconate. It's simple actually. Hydralazine is an antihypertensive, okay, which is and second one, naloxone is antidote of morphine sulfate, and RHD we have discussed in the earlier class that it is given to prevent RH incompatibility. We have discussed in details about RH incompatibility and RH isoimmunization in the last discussion class. So that's why answer is calcium gluconate. So calcium gluconate is the antidote of magnesium toxicity. 10 ml of 10% calcium gluconate is given IV push over 3 to 5 minutes. Hydralazine is given for sustained elevated blood pressure in pre-eclamptic clients. And RH immunoglobulin we have discussed, it is given to prevent RH incompatibility. It is given within 72 hours after first delivery. And naloxone is used to correct narcotic toxicity. It's commonly used as an antidote for morphine sulfate. Next question. A patient with sickle cell anemia has an increased risk for having a sickle cell crisis during pregnancy. Aggressive management of a sickle cell crisis includes which of the following measures? A. Antihypertensive agents, B. Diuretic agents, C. IV fluids, and D. Acetaminophen for pain. So sickle cell anemia is a chromosomal abnormality in which the RBC becomes sickle shaped or C-shaped due to lack of normal hemoglobin. The RBC becomes C-shaped. So this destructed RBC causes obstruction in the blood vessels, resulting in low blood flow and hypoxia to the tissues. And due to hypoxia, the patient will have severe body pain. And this condition becomes severe. It's known as sickle cell crisis. So basically what happens in sickle cell anemia, just like I said, due to the obstruction of the destructed RBC, the blood flow to the tissues will be decreased, leading to hypoxia and severe body pain. So initial management of sickle cell crisis or sickle cell anemia is to administer oxygen, because the basic problem is hypoxia. And why the hypoxia occurred? Because of decreased circulation. So to improve circulation, we administer IV fluids, and then only comes the priority for analgesics. So this is the most important point. The client will always come to the clinic with the complaints of severe pain, but it's not the analgesics which is the priority management. The initial management is oxygen and IV fluids. Most importantly, IV fluids. Okay. And so here, aggressive management of a sickle cell crisis includes which of the following measures? A. Antihypertensive agents, B. Diuretic agents, C. IV fluids, and D. Acetaminophen for pain. So answer is option C, IV fluids. There are different types of sickle cell crisis depending on how it is caused. It's all explained in our classes in detail. Okay. Next question. Emily has gestational diabetes and it is usually managed by which of the following therapy? A. Diet. B. Long-acting insulin. C. Oral hypoglycemic drug. D. Oral hypoglycemic and insulin. So there are four options: diet, long-acting insulin, oral hypoglycemic drug, and insulin. So Emily has gestational diabetes, and the question is, it is usually managed by which of the following therapy? So just like in any other, means just like in adult diabetes mellitus, in pregnancy also diabetes is usually or initially managed by a diet and exercise. Okay, so answer is A, diet. Long-acting insulin is not required in gestational diabetes mellitus. Short-acting insulin is used, and oral hypoglycemics are most important point is oral hypoglycemic agents are contraindicated in pregnancy as it causes lactic acidosis. Oral hypoglycemic agents are contraindicated. So option C and option D is wrong, and long-acting insulin is not required. Short-acting insulin is used, and B is also wrong. Apart from that, usually or initially DM is managed by diet and exercise. So answer is option A, diet. Next question. Nurse knows that the following changes in respiratory functioning during pregnancy is considered normal. So out of the four options, which one is the correct functioning during pregnancy? All the options are related to respiratory functioning. Let's see the options. A. Increased tidal volume. B. Increased expiratory volume. C. Decreased inspiratory capacity. D. Decreased oxygen consumption. So, tidal volume means the amount of air which is moving in and out of the lung. Okay. So, during pregnancy, there will be more oxygen requirement. So, what happens is inspiratory capacity is usually increased. So the mother will take more effort and more oxygen will be gone in. So inspiratory capacity will be increased during pregnancy. Okay, and in an effort of taking more inspiration, there will also have, what happens is the movement of air from the lungs will also increase. So basically, tidal volume is the movement of air, total amount of air moving from in and out of the lungs. So because the mother is taking more effort, the tidal volume, that is the movement of air in and out of the lung, is usually increased. So what happens is the residual volume, means the amount of air which is retained in the lung, will be decreased because of this increased effort of respiration. So residual volume will be decreased, and gradually the expiratory volume, due to the decrease in the residual volume, expiratory, the amount of which goes out, will also be gradually decreased, which is known as expiratory volume. Okay, so what happens? Tidal volume increases, the movement in and out will be increased. Gradually, because of the decrease in the residual volume, the expiratory volume is also decreased. And oxygen consumption, we said in the starting itself, because there is more requirement of oxygen, so the oxygen consumption will be increased during pregnancy. So these are the facts related to the respiratory function. So answer here is increased tidal volume. Okay, so answer is increased tidal volume. A pregnant client breathes deeper, which increases the tidal volume of gas, which is movement of air in and out of the lung, movement of air in and out of the respiratory tract with each breath. This is known as tidal volume. So because of extra effort is made, and due to, as pregnant client breathes deeper, the tidal volume increases. The expiratory volume and residual volume decrease as the pregnancy progresses. Because of the extra effort, residual volume is increased, and as the decreased, and as the residual volume is decreased, gradually the expiratory volume will also decrease. Okay, Inspiratory capacity increases during pregnancy because oxygen requirement is more, so mother will take more oxygen inside. So inspiratory capacity is also increased. Oxygen consumption is also increased in the pregnant client, which is 15 to 20% greater than the non-pregnant state. Okay, so that's why answer is increased tidal volume. Okay. Next question. A client experienced painless vaginal bleeding, has just been diagnosed as having placenta previa. Which of the following procedures is usually performed to diagnose placenta previa? A. Amniocentesis. B. Digital or speculum examination. C. External fetal monitoring. D. Ultrasound. So here patient is experiencing painless vaginal bleeding, and then it has been diagnosed as having placenta previa. Placenta previa means placenta is implanted in the lower uterine segment. So a characteristic feature of placenta previa is painless vaginal bleeding, which will be in a bright red color, and it will be painless. So it just has been diagnosed as placenta previa. Which of the following procedures is usually performed to diagnose placenta previa? And there are 4 procedures mentioned here: amniocentesis, digital or speculum examination, external fetal monitoring, and ultrasound. So one important point related to placenta previa is that per vaginal examination is contraindicated in placenta previa because the placenta is in the lower uterine segment. If we do any kind of examination in the vagina, it might lead to infection of the placenta. So direct vaginal examination is contraindicated in placenta previa. Now coming to the options, amniocentesis. Okay, we cannot do amniocentesis because examination through vagina is contraindicated. Digital or speculum examination is contraindicated, and external fetal monitoring does not diagnose placenta previa, though it is used to detect the fetal distress or fetal functioning or placental insufficiency, but it does not directly diagnose the condition. So external fetal monitoring is also wrong answer. So non-invasive procedure, which is ultrasound, is used to diagnose placenta previa. Okay. Next question. A baby girl is born 8 weeks premature. At birth, she has no spontaneous respiration but is successfully resuscitated. Within several hours, she develops respiratory grunting, cyanosis, tachypnea, nasal flaring, and retractions. She is diagnosed with respiratory distress syndrome, intubated and placed on a ventilator. Which nursing action should be included in the baby's plan of care to prevent retinopathy of prematurity? So a premature baby is born. She had symptoms like nasal flaring, grunting, retractions, and tachypnea. All these indicate neonatal respiratory distress syndrome, and she is diagnosed with respiratory distress syndrome and intubated and ventilated. The question is, what nursing action should be performed to prevent the complication which is known as retinopathy of prematurity or retrolental fibroplasia? So what is retrolental fibroplasia or retinopathy of prematurity? That is important to know. Then only we can answer this question actually. So neonatal respiratory distress syndrome is a condition caused due to the immaturity of the lungs. So proper maturation of the lung does not happen because of the deficit in surfactant detergent. Surfactant is a detergent which helps in the maturity of lungs, and due to lack of this surfactant, the fetal lung maturity is decreased and leading to the complication which is known as neonatal respiratory distress syndrome. And these are the symptoms which are also important: grunting, cyanosis, nasal flaring, and retractions. So the baby here is resuscitated and intubated and ventilated. So now coming to the complication which is known as retrolental fibroplasia or retinopathy of prematurity. Retinopathy of prematurity is also called retrolental fibroplasia and Terry syndrome, an unusual eye disease occurring in premature infants, usually from being given high concentrations of oxygen, which causes abnormal formation of fibrous tissue behind the lens and often results in blindness. So, retrolateral fibroplasia is a condition which causes blindness in the babies because of giving high concentration of oxygen. So, what happens is in premature babies, the retinal layers are not fully developed. So, if you give high concentration of oxygen, it will lead to abnormal growth or scar tissue formation in the retinal layers and behind the lens, which causes blindness. So, it occurs due to administration of high oxygen concentration. So, for a baby with neonatal respiratory syndrome, we should be cautious. Uh, we should be always monitoring the baby's saturation level and oxygen levels, because higher oxygen concentration results in this complication called retrolateral fibroplasia or retinopathy of prematurity. The condition is again explained in details in our classes. So the main points are it occurs in premature babies, those who are having neonatal respiratory syndrome, due to administration of high concentration of oxygen, and it results in blindness. So, monitoring oxygen levels, partial pressure of oxygen, and reducing the oxygen concentration are important, and keeping the PaO2 within normal limits reduces the risk of retinopathy of prematurity in a premature infant receiving oxygen. So, coming to the question right now, 8 weeks premature baby is born. Baby showed symptoms of neonatal respiratory distress syndrome. Which action should be included in baby's plan of care to prevent retinopathy of prematurity? Cover his eyes while receiving oxygen. Keep her body temperature low. Monitor partial pressure of oxygen levels. Humidify the oxygen. So we have clearly explained that it is due to administration of high concentration of oxygen. So monitoring the PaO2 and reducing the oxygen maintaining the O2 level within normal limit are important interventions to prevent this complication, and therefore answer is monitor partial pressure of PaO2 levels. Thank you.